Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Tobb, Dr. Sanghavi, welcome to the Heart of Prevention.
Thank you for having us. We're so excited to be here.
Thank you so much. I'm looking forward to the conversation.
Me too. So today's episode, we're going to be talking about the pregnancy connection. And let me tell you about our two incredibly esteemed guests for today. I'm just so excited for this episode. Dr. Kardie Tobb is the medical director for the Women's Heart Health and Cardio-Obstetrics at Cone Health Heart Care and the clinical integration officer at the Cone Health Center for Health Equity. Dr. Monika Sanghavi is the director of Women's Cardiovascular Health at Pennsylvania Hospital, the associate program director for the Cardiovascular Disease Fellowship Program in the Division of Cardiovascular Medicine, and the associate professor of clinical medicine. We are in for a treat, you guys. I always like to start out the episodes by asking what first really drew you into cardiology, but more specifically, when did you realize that women's cardiovascular health would really become a central part of your career? And we'll start off with Dr. Tobb.
Thank you, Keerthana. So I have to tell you, the first thing, I'm just going way back, my medical school application said pediatrics. I can tell you this. And then it went from pediatrics to obstetrics. And in my fourth year of medical school is when I really shadowed, it was on a rotation, my internal medicine cardiology rotation, Dr. David Adley. He was at PCOM and I shadowed him and just fell in love with what he was doing in terms of the acute care, patient follow-ups, as well as the imaging. That blew my mind. I'm like, I can do all of this? So I was able to really then have to go back, right? Because you think about fourth year, you're talking about thinking about applying for residencies. I had to really go back and ship things for internal medicine, look for letters. But then once I got into cardiology, I thought maybe I would be going into interventional cardiology because I think I'm a go-getter. I'm like this person who wants to be a doer. But after my first year of fellowship, I recognized, and I'm going to acknowledge Dr. Renee Bullock-Palmer, who is actually, I trained at the Boer Heart and Lung Center, and she was a mentor of mine who she's director for Women's Heart Health there. And I kind of really close with her, seeing what she did and all of the work that she was doing drew me to women's health. And I never stopped since. So I'm really grateful for her mentorship, as well as Dr. Adley introducing me to the field of cardiology.
I love that story. I feel like the OB to cardiology pipeline is maybe more common than we realize. Dr. Sanghavi, what about your story?
Yeah, no, I love that, Dr. Tobb, because mentorship plays such a big role in our career decisions. But it's funny that my exposure to cardiology was actually right after college. I worked in a lab with Dr. Chug on sudden cardiac death, and I worked with an electrophysiologist, Dr. Eric Stecker at that time, and he was an EP fellow. He would take me to EKG classes and the cath lab, and I loved every moment of it. But after medical school, I had decided I want work-life balance. And I tried to stay away from cardiology, actually. And I had told everyone that I'm doing something else. And then the problem was I was happiest on my cardiology rotations. You know, I loved the topic. Didn't matter how many hours I was in the hospital. I just enjoyed it so much. And so I sought mentors and I said, what do I do? They said, follow your heart. No pun intended. Then after that, I decided that I'm going to choose a career based on my passion rather than the work life, like the hours that I need to put in. And it was the best choice I ever made because I love what I do. And I think the joy at work definitely makes me a happier person at home as well. And once I had made the decision to go into cardiology, I had the good fortune of meeting Martha Galati, who really sparked a passion in women's cardiovascular health for me that has continued to light my current career path. And so it was her passion that became my passion.
I have to say, Dr. Sanghavi, Dr. Galati has really, Dr. Bullock Palmer was the first for me, and meeting Dr. Galati too has. So we share that. She has really helped us enjoy that because setting the path for all of us in here. So thanks for saying that.
No, and same. Dr. Bullock Palmer has been a huge mentor for me as well. So we share very similar paths.
I love that we're talking about women trailblazing the path for other women. And I do think both of those people continue to really inspire us trainees every day and are still out there kind of pushing us to find our passions. So I love that. Dr. Gulati is actually how I got involved with the podcast. So we all share that in common. So we're
She
going
can
to do
do.
something a little bit different for the next round. I thought it would be fun to do a little bit of a rapid fire round. So I'm just going to ask you questions and you're going to tell me your quick and dirty response to it. And these are going to be related to women's cardiovascular health prevention and so on, okay? So my first question is, what is your go-to one-liner when you're counseling postpartum patients on their long-term heart health?
So I would say my go-to is 80% of heart health is under your control. And I tell young women the choices you make now have impact on not only your health trajectory, but the health trajectory of your child as well. And so let's get started.
I really like what you said. Similar things, but I also I'm going to focus in on one group here, especially women that do have gestational hypertension and forget about it. I always say, don't forget about your blood pressure now. From now on, always keep that cuff handy. Be able to check your blood pressure because you do have a risk in the future that you can develop high blood pressure. And also encouraging them for diet and exercise as well.
I love that both of your answers had to do with empowering these women to like take control of their health even postpartum. So, what do you think is the most underrated cardiovascular vital sign for women's health?
Actually would say I'll go back to the basis of just the menstrual cycle. The reason why I say that is when we start thinking about risk factors in women, the polycystic ovarian syndrome, the irregularity of the menstrual cycle can really tell you the early signs of who's going to have cardiometabolic syndrome and what could lead to hypercholesterolemia or what could lead to heart disease. So I going back to what the NIH said several years ago, talking about the menstrual cycle as a woman's fifth vital sign. And when we are in cardiology, we are outside of that realm. We don't think about the menstrual cycle as impacting what we do. So that's what I would advocate for.
I really like that. My fifth vital sign is pregnancy intention. And so, what I mean by that is there is this beautiful initiative that came out of Oregon called One Key Question that recommends asking every woman of childbearing age, do you plan to become pregnant in the next year? And I think that question is so important that belongs right next to heart rate and blood pressure because it impacts what testing we do. It impacts what medications we prescribe. It impacts the counseling we have. And so without it, I kind of feel like we're shooting in the dark. And I would add to that initiative, not only should we ask, do you intend to become pregnant, but also have you been pregnant in the past year? Because a woman could still be breastfeeding, lipids change due to pregnancy. And if you check right after pregnancy, you could be fooled one way or the other if you don't have that context in terms of information. So that's why I think pregnancy intention and history is part of the vital signs.
I actually
I'm
do.
taking notes.
I actually do like that. The reason why I say that is because one of the things that we're trying to foster here is having our primary care providers, and we have a wide nest of people who will be listening to this. So for you primary care providers who are listening to us, that is the how you really interact with helping with maternal care and helping with cardiovascular care in women is just asking intentions, and we can optimize and set people up for success. I really like that.
I love that. Okay, great. Okay. Here is one that's a little bit of a dreamer question, but I'm going to ask it. If you could fix one gap in postpartum care tomorrow, what would it be and why?
I can take this one first. So, one of my biggest pet peeves is how people attribute every symptom that a woman has during pregnancy to pregnancy. Oh, you're really short of breath, that's pregnancy. You have edema, that's pregnancy. You have chest pain, palpitations, it's all pregnancy. And so what I would say is the gap that I would fix is remember to not turn off our brains and just attribute everything to pregnancy, but actually think critically, what could we be missing? And remember that these women are at really much elevated risk of cardiovascular events around the time of their pregnancy, and we have to have a high pretest probability. I mean, the amount of women I've seen in our clinic who sought medical attention and MI and cardiomyopathy was just not on the differential and it wasn't tested for. And so that's something that I feel strongly about is we can't attribute all women's symptoms to pregnancy if you see them postpartum.
Couldn't agree more. Like you, I see these women that come back, and by the time we're listening to them and getting those echoes, they're far into their cardiomyopathies or their, I see quite a few SVT I've finding in pregnancy from using the monitor appropriately, appropriate criteria. But in addition to that, there's not much I'm gonna add because you really rounded that. In addition to that, the only thing I'll say with the advocacy and education for our colleagues, because when she's pregnant, she does not become a unicorn. She is still a human that needs that care, like you said. The testing that we need to do, the criteria we need to meet, and not just say, well, you're tired because you're pregnant. There are many times that the tiredness has been attributed to the fact that they do have an EF of 30%, they passed out because they actually did have AFib during that period of time. So that's the only thing I'm going to add is the education, but you said it properly, just promptly.
No, I love that education piece because without it, we're not going to make a dent in that, in making a change. So 100%, I agree.
What an incredible point to not chalk everything up to pregnancy in the event that already women are kind of told, oh, their symptoms may be downplayed or they may be, not listened to begin with. And then now when they're pregnant, it's almost like, oh, that's just because you're pregnant. Or we're like, oh, that's normal for you to swell in your legs. But just that component of taking a step back and recognizing, I love the not a unicorn part because that's just so good. Like there's still a regular patient with something else going on. And so to really listen to them, oh, I love this. I've learned so much and we're 10 minutes in. This is great. So what is the biggest myth about pregnancy and heart disease that just really drives you crazy?
So I have to say, one of the things that we really need to debunk is the myth that heart disease is not for young women, and everything that happened during pregnancy, once they deliver, they stop. For example, preeclampsia, the belief of once you deliver the baby, everything is gone. Because the reality is, women who have preeclampsia, we're having this conversation because we know, right? So what we want everyone else to understand with us, like women who have preeclampsia, it doesn't stop there. Their cardiovascular risk increases. Their traditional risk factors can really 2 to 3 years later they could develop hypertension, the coronary artery disease risk. So we need to really debunk that myth that once it happens during pregnancy, I always say what stays in Vegas doesn't end in Vegas in this part of the as far as in Vegas doesn't end there. It comes out to the rest of your long-term cardiovascular health. So I really want people to be able to help us really spread that word that you have this in pregnancy after the fact. We need to make sure we're risk stratifying you. We need to make sure you get your proper testing and treatments.
Love that. And because I couldn't agree more. I have this saying similar to the Vegas one, but instead of what happens in pregnancy should not stay in pregnancy. We have to carry that information forward. And so one of the biggest myths that kind of is very similar to what you said is the idea that after delivery, the risk ends. The risk actually for some women is just beginning. And so we have to understand that. I think most people don't realize that after a woman has preeclampsia or a hypertensive disorder or pregnancy, their blood pressure trend isn't just down, it's actually parabolically up immediately postpartum. And so it makes a parabolic curve that puts them at much higher risk in the 10 days postpartum because of that blood pressure elevation. And so we have to understand that the risk is higher postpartum. Even the more the risk of MI is higher, the risk of being diagnosed with cardiomyopathy is higher. So that risk is much higher postpartum, and we cannot think that it ends in pregnancy.
That brings up a great point that kind of makes me wonder how many patients postpartum that go to their PCP or for follow up, or if they're establishing with a new PCP, even mention that they had preeclampsia during pregnancy. If they are immediately listing that, or if that's something that they're like, oh, that happened during pregnancy, so I don't even think about listing it on my past medical history until they're asked about it.
Yeah, that's a good question.
Yeah,
Mm.
and that's why I think that for us in this field, we need to push and advocate for the obstetrical history to be a standard on every note template. The PCP note template, it is there, but are we really doing it? The cardiologist note template. And the truth of the matter is, unless you start putting your time and investing in preventative type history taken, you're going to miss the obstetrics history because people don't see it as a prevention measure or a risk stratification measure.
I don't think it comes up, right,
Right.
routinely.
Yeah, exactly.
Yes, when someone asks about pregnancy, they don't I don't think patients automatically offer up that information. I think you do have to ask those specific questions. So,
No to ask for it.
Yeah, and I'm
yes.
thinking back, I've never been asked about my pregnancy history at all. I'm being the very physicians and you be my primary doctor. So
Yeah. No, it's important for sure.
Gonna go add that to my template as soon as this we finish this
It's a
recording.
job phrase. It's so easy, just to incorporate. Yeah, for sure.
So we kind of talked about the postpartum and pregnancy period, but what do you think is one test that every woman in her 20s and 30s should really have, whether that's related to pregnancy or just as a woman in their 20s and 30s?
I think kind of related to each other would be a lipid panel and LP little a. I think both of those provide so much information about risk that um, every woman should be getting it with their regular checkup for sure.
I am on the LP letter A train. I'm telling you, now I'm just and you couldn't have said it right. LP letter A is so important now just for our risk stratification, even if the LDL is normal, right? We know there are other things that we have to look for that and how we educate people and families so it become bigger. So I have to agree with LP letter A. The other thing that I would personally add that I always do is just making sure that they're checking their blood pressure, at least not forgetting about that, because then I've had women come 5 years later and say, "Oh, I only had it when I was in pregnancy. I don't know why my blood pressure is high." And I have to step back and help try not to say there's neglect or try not to say there's not proper care, but say, oh,
Right.
that patient could have been different. I intentionally do it and go back to that index case of their pregnancy so they can be able to educate another friend or family member if that situation exists so they're empowered to know that. Don't stop there. Make sure you're checking your pressures or make sure that this happened to me after I was pregnant.
The point of holding on to the blood pressure cuff is so key too. You're like, don't get rid of it as soon as you deliver, just hold on to it. And really, I am just thinking about like my friends' experiences. And they were like, yeah, I had a friend who was like, oh, I have preeclampsia, but they said my blood pressure is fine now. But she's a nurse, so she checked her own blood pressure and it wasn't. And so I think that's something I love that we touched upon, not only educating like our colleagues in PCP clinic or general cardiology clinic or OB clinic, but also kind of advocating for the patient to really take control of their health too. And so they know what their risks are and really empowering them. I love that.
You know what I
What?
do at times? I have to share this, and this is I'll be quick because I
No, I love this.
do you own a blood pressure cuff? And they say yes. Where is it? Where like where in the house do you have it? And is it dusted? Is it clean? Can you touch it? I ask a question because it's almost like do you own a silver spoon? Yes. and you keep moving on. But if you know where it is, then you actually are interacting with that. So I want people to really interact with their patients and not just do the drive-by yes, but to ask the intentional questions that would stop your patient or the person you're talking to be able to say, oh, okay, this is where it is. Let's do this. This is how we do it. So
Yeah, I just want to add that the other time frame that I always harp on the blood pressure is definitely the menopause transition. I'm like, ladies, if you don't have one by now, you need to get a blood pressure cuff because that prevalence of hypertension post menopause is so much higher for women than men. And so I definitely, that's another time frame where I'm just like, got to get a blood pressure cuff.
And then you got to make sure it's dusted and ready for use.
There you go. There you go. And if you have one, take it out and get ready to
Is it
use
in your
it.
line of sight?
100%.
What do you think is one adverse pregnancy outcome that's most overlooked in routine CV risk assessment? Or are all of them overlooked and we're just not asking the right questions?
for me, what I would really hone on is preterm birth. We talk a lot about gestational hypertension, preeclampsia, gestational diabetes, because from a cardiovascular or cardiology standpoint, these are familiar. And it's easy for us to want to remember and associate our careers with it. But preterm birth seems like something that's outside, that's owned by the OBs. So I think pulling that for me, pulling preterm birth and making sure we're recognizing it as a risk enhancer, especially in traditional risk, and then looking at it as an independent risk enhancer, especially if they deliver less than 32 weeks associated with preeclampsia and things like that. That's what I would really advocate and push, that we recognize more from the prevention space.
Yeah, no, I agree with that. I think preterm birth is often overlooked because it requires a little bit more detailed of a pregnancy history. But I would even say I think cardiologists might even overlook gestational diabetes because it's not something that we think about all the time. But, you know, the implication for a woman's cardiovascular health because of that risk of diabetes after delivery is so high in patients with gestational diabetes. I think we cannot forget that gestational diabetes is actually very, very important as well.
I love that. No, I think at least from this rapid fire, we've learned that there's so much about advocacy that needs to happen, so much about patient education. I need to update my pregnancy history template on Epic as soon, like there's a lot of things we have to ask and we need to be more detailed than just a simple yes or no answer.
Especially where your blood pressure cuff is. Do you have a blood I love that. I'm gonna make sure to ask that every patient now.
I know.
Where is it?
So we hear a lot that pregnancy is considered a stress test. And I would love to just dig into why you feel that that's the case and kind of explain a little bit about that. And we can start with Dr. Sanghavi.
You know, I think women as at such a young age do go through like a 9-month stress test. And it's a stress test because it affects the hemodynamic system so significantly, the cardiometabolic system, and even the structural heart changes during pregnancy. And so, um, we know that the cardiac output goes up about 50%. That's a huge change in cardiac output. And we know that heart rate increases. We know that there's changes in systemic vascular resistance. And even from a cardiometabolic standpoint, by the end of pregnancy, women are really insulin resistant. And so what pregnancy does is it unmasks this vulnerability that we might not see clinically otherwise. And I think the reason why it's a stress test is because we see it briefly in that stress test time frame, and sometimes it goes away. But the thing is that what we learn during that time we cannot forget. The same way that ischemia during a stress test tells us about something underlying, the same way hypertension or diabetes during pregnancy tells us about underlying risk, or it can manifest or show up as or under reveal an underlying structural cardiac problem that we didn't know exists, whether it's a cardiomyopathy or valvular problem. And so many things can show up because of the stress of the pregnancy itself. And so that's why pregnancy is considered a stress test. And I think the information we glean during that 9-month time frame, we really have to keep it pertinent in a woman's chart through the pregnancy history.
I love that point. Go ahead, Dr. Tobb.
More, I have nothing else to add. Just, there's nothing to add. I couldn't agree more.
I like the point about unmasking what we know and the comparison to a stress test, like if there's underlying ischemia. I love that, especially as a trainee, because that's something that sticks in my head. We don't just ignore that once the stress test is done. So why would we ignore something that we saw during pregnancy? The analogies are so good today.
No, I mean, like the ST changes after stress go back to normal, even if it's positive, right? Just because they're going back to normal doesn't tell us that they weren't present during that actual stress. And so I feel like that's why I love that term stress test, because it truly is, unmasking or and showing us these vulnerabilities.
Right. So this is one that you kind of have touched upon already, just with the group mentality that this is a team sport. But how can cardiologists, OB-GYNs, primary care providers, how can everybody really coordinate better postpartum care for patients with adverse pregnancy outcomes, maybe with risks that have been unmasked? How can we really all just coordinate our care better?
For me, I think one of the things that I would start with is that collegial communication, starting from there, creating a well-designed program, even if it's not a program for people who are not working in silos, be able to recognize who's doing what and who's the contact, and making sure that you're able to talk about the mutual patients. And sometimes if is that a evidence care pathway you put in place. In our institution here, we have developed our cardio-obstetrics high-risk team that composed of myself, our pharmacist who from a cardiovascular space, maternal fetal medicine, OB, family medicine OB, as well as our anesthesiologist. So we have our monthly roundtable and talk about all these patients, but it doesn't stop there. So, and this is just doing the prenatal care phase. But one of the goals that we're hoping to achieve and we're working on is how do we really optimize those women, as Dr. Sanghavi said earlier. And then who owns that patient after the 6-week OB follow-up or after the 6 months transition? Do they have a PCP? Does the PCP recognize their risky answers, the adverse pregnancy outcomes that have come there? Is that an evidence-based workflow or a guideline pathway? So all those things really play a role, but I think it's also institution dependent and what resources you have, but just identifying individuals who are going to be leading others and helping other people understand is important.
I couldn't agree. That communication piece is so critical to, you know, keeping the care cohesive for these patients. The I've already used a lot of analogies, but I love analogies. And so I think the analogy that I always say in this situation is, for a long time, pregnancy has been an island. It's been an island where you get pregnant, you go to this island, the OBs take care of you, and then you come back from this island with the baby, and then we forget what happened on that island. And so I think in order to coordinate care, we really need to start building bridges. You can no longer have an island. You have to have clear bridges to the mainland. If if and that mainland is your regular care, whether it's PCP, cardiology, anything. And so I think and that those bridges have to be standardized. And so you have to have standardized protocols that allow patients to clearly transition from OB care to primary care or cardiology care. Whatever it is, it doesn't have to be one thing. It just has to be automated so that no one has to think about it. It's happening. So the transitions are happening. And so no one's getting lost in the system. And um, so that's I think the key to the care. It has to be um, automated and really intentional in terms of our plan for postpartum care.
I like that keyword intentional. Because when you do it with intent, everybody gets to be a part of it and feel that they own a part of it, you know? Cardiology saying, well, she's pregnant, what do you want me to do? Or the primary doctor saying, oh my God, I can't do, you know, so yeah, the intentional aspect of it is so key.
Oh, I love those answers. No notes. So we've kind of talked a little bit about adverse pregnancy outcomes, but I'd love to just dig into this. We know adverse pregnancy outcomes disproportionately affect certain populations, including but not limited to African American patients, South Asian patients, Indigenous women. How much of this do we really understand as biology versus just structural inequity? And then, really, what should we be doing both at the systems based policy? I mean, lots of thoughts on lots of things here for how we can really have the biggest impact related to these inequities.
I think there's some biologic differences that are exacerbated by some systemic issues. So I do think that we know even outside of pregnancy that hypertension affects black population more than the Caucasian population or white population, and same thing with diabetes. We know that diabetes is highly prevalent in the South Asian population, whereas it's less so in the white population. And so we know that there are some differences underlying, and we know that pregnancy is a stress test that unmasks some of these differences. However, overlaying that is an imperfect health system where we see that there are inequities. There are racial differences in how care is received, how care is obtained. And so I think that we have to tackle both, understand the biology, but also tackle these systemic issues that we know are there in our health system. And so I think one of the biggest ones is that postpartum care for especially the most vulnerable population on Medicaid. We know that pregnancy, you get insurance through pregnancy, and that extension of Medicaid to 12 months after pregnancy for those who don't have insurance is so critical, so that these that vulnerable time frame after pregnancy care can be accessed, and you don't lose access to that care. So I think that is really, really, really critical, because if you can't even access care, you know, how do we even have a shot at really equaling the playing field in terms of improving risk in all women?
So I agree with Dr. Sanghavi. I'm going to add a few things to, yes, we do have biological things that are underlining this. And yes, she is absolutely right. There are some not imperfect, Joel, take away the perfectly. There are imperfect systems that we find ourselves practicing in. And some of those systems have been rooted through structural racism and based on structures that have been placed that over time the structure stays, the policy shifts, and things have not stayed the same because of the way people are taught and the way people do things, for like biases, not believing certain populations because you think that your perception of what they're saying may or may not be true. So then if you account for the economic differences, if you account for the traditional chronic diseases, and you account for the social economic status and education status, there is still high burden of maternal death in Black women, still high burden of maternal death in women of American Indian descent. And then there is still, the Hispanic women are shifting, but it's not quite there. So in addition to we're doing our work as physicians and we're doing that, we still need to be able to understand what is my implicit bias that I'm implying based on what they're telling me, and how am I shifting my clinical decision? What does that mean? Because the reason why I say that with honing on the structural racism is, if we look at the data currently that we have in the United States, that data tells us that even educated Black woman who has college education, like myself, has a higher risk of maternal mortality who against educated white women, And then when we start calling about other races in terms of South Asian women who have burden of diabetes and things like that. It is an implicit bias based on the things that, okay, a woman who's immigrated to the US, language bias or barriers. So I do agree we do our work as physicians, we do what we can, but we also have to account and be aware of our own implicit biases from the door of the ED till the end of discharge. What are we doing to this person that could impact their care? One, for not coming back for prenatal care after their first experience of pregnancy. And two, to your point, postpartum, they're not coming back for care because they don't have access any longer because of insurance. So we underrate that a lot in terms of postpartum follow-ups and chuck it to non-compliance and no-shows. But half the time people may want to get their care, but they have no access.
Those are such great points. I think that we also have to start meeting patients where they are, right? So, the idea of telehealth has really helps in some situations in terms of overcoming some of those barriers, but that is not the only solution. That's why community-based interventions are so important, where you're meeting patients where they are, where they're going already, to help kind of change the way we practice medicine almost. And so I also think standardizing, care, where we kind of are able to remove that implicit bias, because we're going to treat patient A and patient B exactly the same. It doesn't matter what their race is. That information can be overlaid on standardized care because it may have some additional value, but otherwise we should treat everyone in a standardized way and have these pathways available.
I do agree, though. And that's why we as physicians, we can't shy away from talking about policies anymore, right? Because what we do is highly impacted on policy. So we should talk about proper policies and how we standardize and care for people. I was very happy to hear Dr. Sanghavi, you talk about the virtual visits and things. I use telehealth in my postpartum clinic a lot. However, there is a pause and there's a concern that it may not be a thing of the future. So that's what, as physicians and clinicians, because including now all of our other partners, the APPs and things, we need to talk about policies and identify and advocate for our patients and how we care for them.
Yeah. There's clearly a call to action here to all of the clinicians, both at checking yourself at the door and recognizing that implicit bias. And I love that you mentioned that, especially in relation to no-shows or people who don't follow up. We're quick to chalk that up to non-compliance, especially like in the training in our training settings. And so I think really stopping ourselves and asking why aren't they showing up, and also a call to action to get involved with policy, because that's really affecting our patients' ability to have access to care. So definitely a lot of powerful discussion there. Um, what is one thing that you think clinicians can implement tomorrow? We've kind of talked a lot about what things need to happen, but what is something that people listening to this can really recognize, like, I'm going to change this tomorrow with how they're looking at cardiovascular prevention and postpartum women?
So, in addition to the pregnancy part, history and the question, I think one thing that I notice a lot is um, higher blood pressure readings in clinic are attributed to anxiety a lot. And so, I see women who have really high blood pressures, and I'm like, have you ever been diagnosed with hypertension? No, it's always been because I'm anxious, or because I'm this, or because I'm this. And we have to do our due diligence with home monitoring to see, is this real or not? Is the high blood pressure just a one-time thing, or is it a persistent underlying problem? And I think we ignore it. And I think if I would ask all clinicians to do one thing, is don't assume that high blood pressure in clinic is due to anxiety or white coat hypertension. It might be, but we can't assume that it is. And so that's the one thing I would say would really help change change the trajectory for some of these women.
I'm so glad that we can see each other and you can see my expressions and you see me smiling. So that thank you for saying that. It's always heartbreaking when so there's a story of a girl who had hypertension and she's a real patient who died, came to the ED and it was attributed to anxiety. She was pregnant, came back. She had gestational hypertension. She was treated. She got back postpartum to the ED. Was treated with anxiety. She went home. She didn't attend her 12-week visit because she had died. So anxiety cannot be the answer to every woman's hypertension. There's ambulatory blood pressure checks. There's giving them a blood pressure cuff, or they can get a blood pressure cuff to be able to get their blood pressure. So I can't stress that more. You've said it eloquently. The only thing I would add from another vantage point is making sure you are understanding why your patient actually is attending your visits, but not taking their blood pressure medicine. Because if they're there, that means that they care about their health in some levels and they're not taking the medicine. Just pause. Not because they may be dressed nicely or so, they may not have access to be able to afford it. Ask them the whys. Maybe they actually are having true side effects. Just listen to them for once. Because I'm really urging our colleagues that know the why behind the reason. You said it, Keerthana. If you can understand the why, our mentality will shift a lot and we'll really see our patients as actually collaborators of their care, partners in wanting to do the right things because they may not know where they can get help for access for medications, but they come because they really want to respect your profession and know that you can help them. But maybe they're just waiting for you to ask them that question. Why haven't you done this? Or why didn't you come the last time for your visit? It's so important.
Yeah, I couldn't agree more. There was a time during COVID, actually, I had a patient who every time she came, she wasn't taking her blood pressure medication, and I asked why. I exactly asked that one question, and she said it so. She said to me, "I can either choose food or medicine. You tell me which one I should choose." And it broke my heart because it's like what my assumptions were so different than the reality in front of me. I literally, I think, didn't say anything for a minute because I was like, "Oh my gosh," we sometimes forget that all the challenges that patients are facing, and so I love the idea of asking why.
Yeah, opening the door for a very non-judgmental discussion about really understanding where they're coming from. It brings back to your point of meeting the patients where they're at on multiple levels and really understanding. The point that you made about a patient showing up for their visit even while not taking their meds was just one I hadn't even considered until you brought it up, right? Like they keep showing up, so they clearly care, but there's something else going on, and just taking a minute to figure out why is just really, really powerful. I want to pivot a little bit with this question, but working in both prevention and pregnancy related, cardiovascular disease can sometimes be emotionally heavy. How do you really that, you know, balance that and avoid burnout?
I agree it's heavy. Sometimes the discussion is heavy, but I also think a lot of areas in cardiology are, whether it's an MI or heart failure. So I think going back to the why are you here? Why did you become a cardiologist? And taking a few minutes to reflect on where you are, why you're doing what you are, I think really helps with that burnout. It definitely rejuvenates me or refreshes me because I realize that I I want to be here. There's nothing else I want to be doing, and it can be hard. It can be hard on a day-to-day basis. It can be hard long term, the amount of hours we put in. But to my original point, follow your heart. Go where you got to be doing what you want to be doing. And this, for me, this is definitely it.
Follow your heart as the two thing about it. So, and you said no pun intended, so it's not. And I love that, right? Because family members say follow your heart. Everyone said follow your heart. I like that. There's nothing else I would rather do at this point in my career in my life because It's hard at times, but the fulfillment and the reflection. And every season as I do this, there's one patient story that carries me along. The most recent one is a 41-year-old woman who had coronary artery disease, MI at the age of what, 32 or something earlier. She had diabetes type 2. EF was low. I think it was around 40. I don't remember the marker now. I meet her 6 years ahead. She was transitioned to me, one of my partners, which was interested in having a baby. She came from a different state where she was told that she wasn't going to be able to get pregnant any longer. And my partner was like, no, she'll take care of you. Go there and, you guys talk. So fast forward, she now have a 6-month-old baby that she visited with 2 weeks ago. And in a sense of gratitude, just sitting there and saying, you guys, thank you so much that I have a gift that I never thought I would have. That moment became a refreshment of the next couple of months for me. And when I think about that and I reflect on it, like she said, she had a gift that she never thought she would have. For me, she's one person. You know? But for that little baby, she's the only mother she would ever have. And for that mother, she's the only child that she ever wanted. So it really kind of goes with me every time. But now I should do my self-care though. I kind of Zumba joy. I have 2 daughters that kind of keep me straight when I don't cut the sandwiches right. The edges are just and I enjoy doing things with them. So those things really keep me whole because sometimes it's a hard day and I have to stay home, I have to stay at work maybe for another 30 minutes before I can really take, because my drive home is not far. It's about 20 minutes. When I was in New Jersey to Philly, it was like, I know, Dr. Sanghavi, you're enjoying the Philly traffic, but it, it was longer, so I was able to leave New Jersey, cross the bridge, and then get home to Delaware County, PA. That's at least a 40 minutes drive. But now I have a 15 minutes drive in North Carolina, so I stay here and get myself together, and then get home and can't wait to enjoy my kids. So that's really keeping me whole.
So I think your point to the patient stories, it really, really makes a difference, especially when you see these patients in follow-up, because preeclampsia can really cause some PTSD. Patients are so scared after they've had an episode of preeclampsia that affected their pregnancy, their child was in the NICU. It it hits deep, and the emotions that come out in that postpartum visit are it they're so, heartfelt, and seeing these patients in follow-up and, after their second or third child and they're doing better and they're so thankful, for, that the care and for someone who understands the empathy that you provide in the postpartum visit. It really matters, and so I think the patient stories and some of those, they definitely keep you going. Mm, I love them. And my daughters too. I have 2 daughters as well, and they keep me, motivated outside of the hospital, and I'm very thankful to the support of my family too, because, whenever things get hard, I have their support, and that really helps for sure.
It's so important though, a supportive family, a supportive spouse. And I remember when I was not going to apply for a cardiology fellowship, and my husband asked me, he said, "Why wouldn't you?" And I couldn't answer the question. I was like, I guess I just have to do it. So
That's such a great point. I love that, you both are so passionate about this. Like I can just feel the passion and love you have for the field. And like especially, I'm a third year fellow now. I just hope that when I'm, in my career, I love and care about and find something that I'm just so passionate about the way that you both talk about it. It definitely, you can feel the passion as you guys talk, and just the relation to the patients and advocacy and all the topics we talked about. We really bring it back to the patients and the stories that you shared of your patients, and getting to be such a big part of such a wonderful moment in a patient's life, and to be there as a support throughout their journey is just really powerful, truly. I may be sending you guys emails afterward. I think I've been convinced this is where I need to go.
I can't imagine a better field. Honestly, I cannot.
This is a question that I always like to ask for the trainees that are kind of listening here on the side, as in me. This is a question for me. What advice do you have for fellows who really want to build a career at the intersection of prevention, pregnancy, cardiovascular disease? Maybe their program that they're training at doesn't have much exposure to this, or where should they be going or reaching out to kind of develop their passion for that? Is it too late? When should they start?
So I would say this is, if you have the Venn diagram that you just described, prevention, you know, obstetrics and cardiovascular disease. So that's the Venn diagram. And we're kind of at the center of it. It's honestly the best combination, in my opinion, because you get to care for these amazing patients. You get to implement prevention strategies early. And in some patients, you're actually trying to do primordial prevention. There is nowhere else do we practice primordial prevention than in patients with preeclampsia and these postpartum patients. So I actually think that's phenomenal. And then the last is the thinking and the critical thinking of a cardiologist and trying to, I can't think of a better intersection, and it's never too late. I don't think it's ever too late. And so it doesn't matter when that spark of passion is started, just follow it, and, either get additional training or seek out people who do similar work. It doesn't have to be exact, it can be someone who does similar work, and um and and just start. You got to start somewhere.
I agree with you. Take the first step, and I like Dr. Sanghavi, you said it so well. And I couldn't be doing anything different from what we're doing now, just looking at prevention, looking at cardiovascular health, and looking at the and it's a matter of equity too, right? Because we're making sure that women get the best care that is intended for them based on why they're there. And getting involved in organizations as a fellow, if you don't have that program at your hospital or program, get involved with ASPC. You're part of working groups, meet people, ask questions, ACC. There's a lot of other ways that you can really hone into your path, your clinical path or your research path without having those things available at your current training program. That's what mentorship and sponsorships are for, because then people help you develop your own path. And a lot of people are willing to do that, but it's just are not interacting with these fellows who want to do these things. So just be a part of the organization, get involved with those working groups and meet people.
One other thing I would add is, if you're in a fellow in fellowship and you have a passion, and then maybe that is not supported in that fellowship in the sense that they don't have the expertise there. That's okay. Every presentation you give it on that topic, because you will slowly become the expert there. And what will happen is your co-fellows will come to you with those cases, because everyone will have those cases in the hospital. And so as you build your expertise, people will start coming to you with those cases, or people in your division will know that that's your passion. So if any opportunity comes up that aligns with that passion, they will think of you. And so I think one way or the other, you can get there. It's just about, if you have someone there, take their mentorship. If not, build your own expertise. It's a slow process. No one's, all of us are learning. I'm still learning every day. And so I'm still building my expertise. And so you got to start somewhere.
Continuing process for all of us. So
This has just been such an incredible conversation. You both are incredible speakers and so passionate about, women's cardiovascular health. And this is the first episode in a series we're going to be doing talking about women's CV health. We started with pregnancy. We're going to be talking about other periods in a woman's life. And this was such an incredible introduction. And for people that don't know a lot about the space, I'm sure they're all incredibly motivated, as I know I am. I definitely have some action plan items from what we talked about. both at my personal clinic level, but also just at our institution level, and really like educating and opening those discussions and dialogues. And this was honestly just so much fun. And I loved getting to chat with you both. And I'm so grateful that we were able to talk about this.
This was really fun. I always love talking about women's cardiovascular health, and to be able to do so with both of you has been just such a pleasure. Thank you so much.
Thank you so much, Preethna and Dr. Sanghavi. It's just, I felt like I was talking to two old friends, just talking about
Yeah.
how we can do things better for women's cardiovascular health. And thank you so much for having me with you too, because I learned a lot from the analogies and also from your call to actions, and reminding myself that, okay, I have to also implement some of these things, what she's saying, that pulling it out here. So thank you.
Thank you guys so much.
Thank you.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.